speculum, your thin prep vial that your samples go in. This is what we send to the pathologist to get our PEP results. The tools that we use to get the PAP, so I'll go over these. So this is the broom. I know Dr. Cronin went over these. This is used to get an ectocervical sample, so it goes into the os and is rotated 5 times against the outside of the cervix to get our outside cervix sample. An alternative to using the broom is the spatula, so you either use one or the other to get an ectocervical sample. Typically at the clinic we use the spatula because it also has the vaginal spatula on the other end. So this side is used for the cervix. The bigger bump is what goes into the os, while the littler curved part is what scrapes around the outside to get the cells. And you just rotate that one full turnaround, 360 degrees around the outside. That's how we get an ectocervical sample with this. For standard screening, we don't usually check the vaginal cells unless they have a history of vaginal polyp, vaginal cancer, DES exposure, something like that, in which case you would gently scrape along the sides of the rugae on both sides. You know, you're just scraping so you get cells, and you vigorously swish it off in this vial, and you look at it and you see some tissue floating around, you know you got an adequate sample.
Just confirming, you said vaginal, right?
Vaginal for the flat spatula end. This is for the cervix. And then the cyto brush. Oh my god. Yes, it's killing the scopette. This is the cyto brush. Okay, so this is for endocervical sampling. So this actually goes 3/4 of the way into the os and rotated 180 degrees, so 1/2 turn. And it pinches a little bit, so you want to tell your patient it'll pinch a little bit. It will have a little bit of blood on it as you pull it out. That's normal. I don't want you to be concerned. But you're not really doing these tests. But when you do, there will be a little bit of blood, so just know that. And then you'll take that out and vigorously swish it in the vial as well. This is a scopette. It's supposed to look like a huge Q-tip. It's been through a rough day. But we set one of these out just because sometimes when you insert the speculum, there's a little bit of discharge in the canal. That's normal. That doesn't mean she's having an infection. That's just what, you know, that's what happens. So you want to get that out of the way before you do your PAP sampling because that can interfere with the results or interfere with your ability to get cells from the cervix. So we use these big Q-tips to just kind of get that discharge out. Everything here is disposable, so once you use it, you just throw it in the trash, not the biohazard, just the trash can. This is what the specula look like. There's 3 different sizes, so white, green, and blue. So white's the smallest. That's what we'll use today on the models. It has the shortest length of blades. It's the narrowest and smallest speculum. This is used for young women, teenagers if we have to, or women who have very sensitive issues going on, whether that's vaginal atrophy, you know, pain during sex, like menopausal women, if they're very sensitive. Typically, we start with the green. This is a medium-sized speculum. This is average, and this works for almost everybody. So for your test, you'll start with the green, but today we'll practice with the white. They're exactly the same, just size difference. That's it. And then the blue is the largest of them all. This is for women who particularly have a large vaginal canal, like a very long canal. Everything differs, so sometimes it can be longer or shorter. Women who are overweight and you're having difficulty just visualizing the cervix and the rugae, you can use a little bit bigger of a speculum to get a better visualization that way. So I'll let you look at those. What else? Nothing else, I think. We'll just, any questions so far, just what's here?
The light?
The light, yeah. So these are meant to have a light in the bottom of them. It's a little black, slender piece that fits into the hole in the bottom of the speculum. And you'll have them for your exams, but they won't let us borrow them because they're expensive. So they just pop in the bottom, and they click. And when you hear the click, the light turns on, and it shines a light all the way down the speculum and through the vaginal canal, so you can see everything just beautifully. So you'll have those for your exam, but you won't have them today. Sorry about that. Good question. All right, so then we'll go into the flow. Oh, yeah.
So in the lecture that I wasn't entirely clear on it, but everything but the big Q-tip is basically
possible to use for a
they
PAP.
all
You're
do
not
the same,
going to use all
same
3.
thing.
No, you're either going to use the cyto brush and the spatula, or the cyto brush and the broom. You either use the spatula or the broom.
Okay.
These are for collecting the outside of the cervix, the ectocervix samples. The cyto brush is the only thing that we have that collects the inside, the endocervical sample. Okay. So some docs like to use the broom. It might be more comfortable for some patients, but we typically use the spatula in the clinic just because it has that vaginal spatula on the end. If we need to use it, we already have it there. We don't need to so you know. All right, Dr. McAllister is going to be my patient. I almost sort of go through the flow. So when you leave your patient, you'll tell her to remove all of her clothing. She can leave her socks on if she likes, but she needs to take off her bra and her undies as well. We're just going to do the breast exam, and then we're going to go right into the pap. So gown open to the back. Make sure you tell her gown open to the back. And usually we'll give her one gown, and we'll give her a sheet to cover her legs for modesty. So she'll be sitting just like this when you get in the room. And she'll be sitting upright, so you'll just go ahead and go into the breast exam when you walk in. So I want to have you go ahead and take your gown down to your waist, and you want them to take their arms out of the gown, right? And so you're just going to do a visual inspection at first. Let her know I'm just going to visualize the area, make sure everything looks okay. You're looking for nipple retraction, dimpling, discoloration, any obvious lumps or bumps, anything that looks unusual, one breast being abnormally larger than the other. Usually you can visualize all the breast tissue, even the sides, just by moving slightly to the side. Please don't make a circus show out of your patient and really be moving all over the place where she feels like she's on display and you're all up in her area. You can usually cover everything just moving slightly to the side. And then you can have her just follow my exercises. So raise your arms all the way up. You're looking at the breasts as they move all the way down into your hips. Good. Squeeze your shoulders forward and bend forward. Great. Everything looks good. You're looking for motion. Do they move symmetrically? Does anything dimple or retract while she's moving versus when she's sitting still? Everything looks good. So have you put one arm back in the gown and leave one arm out for me. You can go ahead and lie back. Put your right arm over your head. So we just want to make sure the right arm is over the head. That really spreads out the pec wall, makes it much more easier for you to palpate the breast tissue, especially if she has large breasts. If she does have extremely large breasts, like D's and higher, you can place a folded towel or a folded sheet under the shoulder blade to help elevate that area and spread it even wider to get through the extra tissue that you'll have to palpate. So there's several different ways to do breast exams, and I'll show you all those on the model, but we always are going to use 3 fingers, and we're always going to use the pads of our fingers to palpate. And you want to keep your fingers flat against the skin. You don't want to be up here poking. That causes discomfort, and you're not really palpating with the best part of your finger, which is on the bottom pad. So just for demonstration, I'm going to go horizontally, but we do 3 concentric circles, light, medium, deep, and I slide my hand across the skin. Don't pick your hands up because something might roll underneath your hands that you feel and that you might miss if you take your hands off the skin. So light, medium, deep, slide, light, medium, deep. Breast tissue goes all the way from the collarbone of the sternum all the way out to the mid-axillary line, down to the bra line, and back to the sternum. So you need to palpate all of that area. And when you're teaching your patient to do the breast exam, you need to let her know breast tissue goes all the way out here, especially out in this upper outer quadrant. That's where cancers are mostly found, not so much in the majority of the breast tissue itself. So we're palpating, and I might ask you, do you do regular self-breast exams?
I don't.
You don't? Okay, well, it's ideal to do it about once a month. Okay, usually 1 week after your period is easiest. There's less hormonal stimulation. Breasts aren't so tender. It's easier to palpate the tissue.
How do I do it?
How do you do it? You do it just like I'm doing it. So first you'd start looking in the mirror, moving your arms like we did, checking the skin, and then you just want to palpate just like I'm doing in little circles, light, medium, and then deep. You're feeling for something that feels like a blueberry or a pea,
Okay.
right? I'll show you what normal breast tissue feels like. You can teach your patient what glandular tissue feels like because it's a little abnormal, a little bumpy, so she doesn't get concerned when she's doing it at home by herself. You want to make sure you're covering all the areas we talked about under the collarbone, all the way over to the armpit and down the bra line, looking for any tenderness or any unusual bumps. You can't do it 1 week after your period. It's okay. You just want to be consistent with the time of the month that you check. So always the beginning of the month, always the end.
Okay.
All right? Nothing felt abnormal there. You don't typically check for nipple discharge on a screening exam. Either standard of care is if a woman presents with discharge, then you go ahead and check. So you won't be doing that for your exam, but I'll show you how to do it on the model, just so you know. So now we're going to check lymph nodes. So arm come down, make sure the arm is relaxed. You can either hold at the wrist or at the elbow. I like to hold at the elbow. I just have a little bit better control. There's 4 walls you need to check. The pectoral wall, let me know if anything's tender. Right, the lateral wall, subscapular wall where you need to feel the anterior underneath surface of the subscapularis muscle, and then the central, which is right in the center of the axilla. Checking to make sure nothing's tender. No, great. Go ahead and put your arm back down, and we'll take the other arm out and do the other side. And so basically, it's exactly the same thing. Arm over the head. You're going to repeat the exact same way. I tend to keep, you don't want to have your other hand touching the patient anywhere. A breast exam is a one-handed exam, not even on top of the other one. So keep it at your side. I put mine behind my back, just somewhere where it's out of the way and not odd. So you essentially do the same thing. When you're palpating over the nipple, it's just treated just like the rest of the breast. There's nothing special that you do over the areola. You don't need to press down and palpate the actual nipple itself. You'll get the tissue underneath the nipple because you're moving in concentric circles, and you're going to be, rubbing the tissue back and forth, so it makes it less inappropriate for the patient. And then again, you would just do, lymph nodes. The arm's nice and relaxed, and I'm checking all four walls: pectoral, lateral, central, subscapular. Everything feels good, so you can go ahead and put your hand back in the gown. We'll begin the speculum portion of the exam. So just so you know, there's a footrest on every bed, so when they lie down flat, their feet are out. The stirrups are underneath that, so you pull them straight out. To pull them out to the side, you have to lift them up first, and then you pull out, okay? They pretty much all work like that, and they fold, and you can move them back and forth so that your shorter patients don't have to be, lunging and falling off the bed. So you pull it straight out first, and then lift and pull out to the side. They come with pink, foam covers that the feet actually go in that make it a little bit more comfortable, but for some reason I don't have them here today. We'll explain. So first we're going to do the speculum part of the exam. We'll do the pap, and then we'll do the bimanual part, which is where I palpate your ovaries and your uterus and make sure everything feels healthy. Alrighty. So ideally, you'd have all your tools set up over here, or your partner, whoever's going to help you that day in clinic, will be right next to you handing you things. In real life, these tables have a pouch underneath where you can put all your tools, so you have everything in front of you, so you don't need to touch anything that's not sterile, and your little, all your tools and your prep vial is all right there for you to make it easy. Just so you know. So I'm going to go ahead and lower this, and I typically will guide my patient's foot into the stirrup. You can tell them to put their feet in the stirrup, that's fine, but she might not be able to see, she might be uncomfortable, so I just take her foot and guide her, and then put the other one in, and I think that's where we'll stop with you. It's right here. Yeah. Thank you, Dr. McAllister.
You're welcome.
That's very good. So then you'll have her, typically we put our hand against the back of the bed and say, scoot down till you feel the back of my hand, either against your thigh or against your bottom. Or you can just tell her to keep scooting until her bottom is at the edge of the table. That's where you want it, right? So keep scooting, keep coming down, or just until you feel my hand. Okay, that's good. So she'll have a sheet over her legs. You can bring the sheet up to mid-thigh. You don't need to fully expose the area. Mid-thigh is good enough for you to be able to see and do everything you're going to do. Grab some stuff, and you guys can come closer if you want. Get all our goodies. In addition, we also have lube. I don't have it here, but just don't forget we have lube. You'll need 3 gloves. 2 on your dominant hand, because we're going to remove one from doing the PAP before we do the bimanual exam, right? And then 1 on the other hand.
Is there a reason we're doing the bimanual after taking the samples?
That's just commonly how it's done.
Okay. Because I just feel like after you poke
You're
down and
irritating.
stuff, yeah.
Just
kind of want it to be over that way.
Although, after doing a bimanual exam, you could mess with the sample because you've been poking at the cervix. So we typically always just want to get a clean sample and do nothing that could interfere with the results before we go ahead and do everything else. So I have 2 gloves on my right hand, pretend I do, because I lost my glove somehow, and 1 glove on my left because I'm right-handed. So she's sitting in the chair. You're going to raise the sheet up to mid-thigh and say, okay, I'm just going to examine the area. Anytime you start a physical exam and a gyne exam, you always just want to touch them somewhere benign, like on her leg, and let her know this is your touch, so she knows you're going to proceed with the physical part of the exam. Sometimes they can't see under the sheet, and it's just nice to let them know. So I would touch your thigh and say, okay, this is my touch, and I'm just going to slide down. I'm going to palpate your lymph nodes, let me know if anything's tender, then I'm just going to examine the area and make sure everything looks healthy. Right? So you can palpate the lymph nodes at the same time on both sides. There's no need for you to do one side and then the other. I typically start at the ASIS and just follow the inguinal crease about to here. If anything else is tender, then I might do a little more palpation in the thigh, but there's no need to continue palpating down in this area. That's just weird, right? So it's exactly the way you learned to palpate already, making sure nothing's tender, swollen. All right, that looks good. I'll scooch down for you. So you're seated on your stool anyway, like I am. So now you're just going to say, okay, I'm going to spread the tissue and visualize the area. So you're going to spread the tissue with your hands. You might have to spread the labia, minora, and majora. You need to be able to see the clitoris, the urethra, the vestibule, the vulva, all of it. You're looking at the hair. You're looking for nits, lice, flaking, warts, anything, discharge, rashes. You especially want to check the perianal area because we can't see there, and sometimes we have benign things we don't know about, like external hemorrhoids or skin tags or warts that we might not know about that would be pertinent to why we're doing this exam. So it's really important that you check that area. You can let her know everything looks good, the tissue looks healthy. Now you're just going to milk the urethra, so let her know I'm going to check your urethra. I'm going to insert a finger into the anterior portion of the vaginal canal, maybe just 1/3 of your finger needs to go in, and you're gently pressing up on the anterior part as you slide it outward. You're milking the urethra, right, because the urethra is anterior to where you are. It's a very subtle motion. You're just checking anterior to the, the upper part of the vagina that nothing is excreted out of the urethra.
You're going into the vaginal canal.
You are, but the urethra lies right on top, and so you're pressing it from underneath. And then we'll check Bartholin's and Skene's glands. Bartholin's glands are about 5 and 7. Skene's glands are about 10 to 2, 11 to 1, somewhere in there. So I typically do one side with my right hand and then the other side with my left. You need to insert one finger, your index finger, behind the labia, and then the thumb goes in front, and you're feeling the gland between your thumb and your forefinger. All right? It shouldn't be tender. It might feel like a tiny little bead. You might not feel anything at all. That's completely normal. That's Bartholin's, and slide out for Skene's. Any discomfort? No? Okay. Same thing on the other side. Bartholin's and then Skene's. And you're done with that part of the exam. So now we're going to do the speculum part of the exam. You just let her know. So you'll have your speculum. You'll have your lube. You can insert, because we're doing a PAP, we don't want to have lube on the lower 1/3 of the speculum. That will interfere with our results. So when you do use the lube, only on the upper 2/3, on the top and the bottom. So you drop it onto the speculum. You don't want the tube to touch the speculum because it could contaminate it. You would have to use a new speculum if you do that. So we just drop it on, and then you rub it on the top and rub it on the bottom. When you hold a speculum, you hold it between your second and third fingers like this. Okay? And you're going to use your thumb on the back part. This little plastic part is what opens it so that you can see the cervix. And the white part, we press up to release that plastic piece when we want to close it. Okay? You use all of this with your thumb. You're not ever going to do anything else. Your other fingers are pretty much going to be around it. So we put our lube on. We put our light in the bottom. It clicked on. There's light coming out here. We're good. I'm going to let her know again, okay, this is my touch. We're going to start the speculum exam. You might feel something cold. You might feel a little bit of pressure, but it shouldn't feel uncomfortable in any way, so please let me know if it is. You want to go in at an angle. We turn it sideways so that the bills or the blades of the speculum are longitudinal, so it's more comfortable when you're inserting. And then we're going to rotate it as we further insert, okay? So you always turn it to the side. You want to have it at about a 40-degree angle or the angle of her thighs, whichever. It's hard to tell. She doesn't have any thighs, so I'm just kind of going in blind. Well, we get there. So you're going to let her know, this is my touch. We're going to start the exam. You can spread the tissue with your hand. Go ahead and insert, and then remove your hand. And as you insert, you're rotating back. I'm going to take my hand out of the way and continue to push forward. On these models, it's not as obvious, but you usually will go all the way, the full length of the speculum, all the way up here. So you're going to continue to kind of press forward a little bit to say, okay, you're going to hear a couple clicks. That's you opening the speculum. 1, 2 is usually enough. So stop at 2, take a look. You might need to wiggle it around a little bit. These plastic models don't make it so great, but it should look like this. You want the speculum, you can come take a peek if you want. you want the speculum to be on top of and underneath the bottom of the cervix, so that that circle is the os. That's the centerpiece of the cervix. Can you see it?
Did you say that you put the light in before you?
Correct. You put the light in and it's on before you insert it. So it should be right in the center, and this is kind of holding and capturing the cervix and keeping it in place. Okay? Sometimes it's not that easy. Cervices can be like down to the side, so you might, that's why I say you might have to wiggle it a little bit. If it takes you a minute or two, that's totally fine. If you still can't get it, that's okay. Then your proctor will come help you. But we want you to try and do it on your own first. So you're in. So now we're going to do the PAP. We're not doing these in real life. You can't do multiple PAPs on a person in one day. So you're just going to tell your proctor what you're doing and demonstrate that you know how to do it. So you can say, if it was indicated, we would take a vaginal sampling on the rugae, because we don't normally do that for a screening exam, right? We just do cervical. So you could pretend to scrape the walls on one side, scrape the walls on the other side, make sure you don't touch anything else going in or out, and vigorously swish in the vial. Look for cells, okay, we're good. So then you switch it around, and you're going to put this into the os. Remember, the big part goes into that center os. The little part's what scrapes around the outside and gets the cells. So you have to be careful not to touch anything. Put it right in the center. One full turn, 360 degrees. Pull it out. Swish, 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 swish. We're done. That goes in the trash. And then we'll use our cyto brush. Let your proctor know this is for sampling endocervical cells. You'd insert it into the os 3/4 of the way, 180-degree turn. Pull that out. Vigorously swish that in your vial. Check to make sure you got some cells. Throw this away. We're all done with the PAP.
They all go in the same vial.
They all go in the same vial. When you do a real PAP, you check which types of cells you have in there, vaginal, endocervical, or ectocervical, so that they know what they're looking for.
In the exam, are we actually going to insert the brush? And no,
you're going to pretend.
You're just pretending.
And you're going to tell me what
you're just
doing.
going to talk through it, not actually
You're not going to actually do it.
Okay.
No, we are going to actually stick anything down there. Or just going to be like, this is what I would do in theory.
Dr. McAllister, do you know that specifically? Whether they're inserting the brush but not touching?
You're going in into the speculum and
pretending to turn it. Okay.
So it doesn't go into the vaginal
You'll
canal.
not touch the cervix. You're in the canal. You'll probably go, okay, so I would turn this 180 degrees. You're just faking it. Going halfway.
Okay, like that.
Like that.
You're going into the speculum just a little bit, but you're not actually.
And 180-degree
Okay.
turn. And then pull out.
Perfect.
Okay. So we're done with the speculum portion. So you can't just pull the speculum off the cervix because it's holding it, right? And so if you pull, it hurts. So there's two ways that you can. Oh. Is this bringing to light something? You can try and wiggle it gently off. Sometimes that works and sometimes that doesn't. If it doesn't come off immediately, don't keep pulling. Just open it up one click more so that it's actually taking the pressure off of the cervix, and then go ahead and pull it off the cervix. Once you're off the cervix, let your thumb press up on that white piece, and that will close the blades. Right? And then we're going to rotate back to that vertical position we had, and we want to come back to that 45-degree angle as we pull out, just the way we came in. Any questions on that?
If their cervix is not directly in front, if it's superior to the sides,
then we try to find it. We
but
never
even
know
with,
that.
But even with let's say it's superior, with the shape of the speculum, how would you get to it?
You kind of scoop.
Oh, you scoop, okay.
You duck and weave. No, you scoop. You don't know that going in unless you had inserted your finger to try and find the cervix. So that's just how it is for everybody. I mean, I wouldn't know that either, right? So you do your best. That's why I say do your best. So now we're going to do the bimanual portion of the exam. So you're going to be standing for this, and you're going to take the glove off your non-dominant hand because you'll be palpating with this hand, and it's always better to have hand on the skin, not on the gown, not on the sheet. I'll take my first glove off. I have my one glove left on my hand. I'm going to let her know again. I'm doing the bimanual. I'll be palpating your ovaries and your uterus. Let me know if anything's uncomfortable. So you have your lube. You can, drop the lube onto your 2 fingers, same fingers we use for the speculum. Spread that out on top and on bottom. There's 2 ways to insert your fingers. You can do it palm up, but I find it much more comfortable for women if you do it just like the speculum exam. Start with your fingers vertically and then rotate them as you get deeper into the vaginal canal. Make sure that these fingers are out of the way, that they're not flopping around, touching perianal tissue and making people uncomfortable and whatnot. So again, this is my touch. Let her know you're going to start that part of the exam. You can't spread the tissue because you don't have a glove on this hand, so you really don't want to be touching that area. And having just done a speculum exam, it's pretty easy to just insert your fingers. That's not a big deal. So go ahead and insert her fingers. You might feel something cold. Again, you might feel pressure. It shouldn't be uncomfortable. Rotate your hand. And you want to find the cervix, and you want to be right underneath it. So if this is the cervix and this is the os, I'm bringing my hands right directly underneath it, and I'm going to wiggle it like twice or 3 times. And that's your cervical motion tenderness. You're just checking to see if there's any discomfort there. So wiggle that. Is there any discomfort? No? Okay, good. Now we're just going to palpate the uterus. So typically the uterus lies behind the pubic bone, but we don't know that. We don't know if she has fibroids or how big her uterus is or where it is. So I tell students to start at the umbilicus, and you're kind of making a scooping motion with your hands. You're pressing down into the abdomen, and you're trying to capture the uterus with your left hand. Meanwhile, the hand that's in the vagina is lifting up underneath the cervix, trying to bring the uterus to you. So you're pressing gently up. You're not like really like ripping it up, but just a little pressure upward.
You're pressing the cervix up?
You're pressing the bottom of the cervix upward. You're trying to lift it just a little bit.
Okay.
Just a little bit. And then you're trying to meet the uterus with your left hand. Once you feel it, oh, okay, it's right here, then you can continue kind of palpating and scooping in a local area where you felt it, like right around the pubic bone. So I'm just going to feel, make sure I don't feel anything abnormal, make sure she's not uncomfortable, right? And now that you know where the uterus is, you know the ovaries are going to be on either side of it. But, you know, I always start a little bit higher because I'm going to try and capture the ovaries between my hands. So whichever side ovary you're checking, you need to move your hands to that side of the cervix. So I'm in the right fornix. I'm in the corner of the right cervix. The cervix is over here to the side. And I'm going to start a little bit higher than where I think, her ovary is going to be. And again, that scooping motion, I'm trying to capture the ovary between my 2 hands. I might feel it with my right hand. I might feel it with my left, or I might feel it in between them. So I'm just kind of scooping like this, trying to draw the tissue in between my hands so that I can feel it. It feels like a little ball. It's about this big and it's soft, like a little round ball. It shouldn't be tender, but you should feel it. If you find it, palpate it for a second. Ask her if it's tender. If not, great, move on. Move your hands to the other fornix, the left side of the cervix. Same thing, start a little higher than where you think the ovary is going to be, and that scooping motion trying to draw the ovaries in between your hands, right? When you find it, palpate it, make sure you don't feel any cysts, that she's not uncomfortable, and you're done with that part. Before you pull your hands out, have her do a Kegel. Ask her if she knows what one is. If so, great. If not, it's like trying to stop the flow of urine. It's using those muscles. You can say, pretend you're trying to stop the flow of your urine. She'll squeeze against your fingers. You're checking her muscle tone. And then you want to have her bear down as if she's having a bowel movement to check for prolapse. So you'd be checking to see if the uterus is coming towards you, if the cervix moves towards you. You can also visualize, the external area to make sure there's no rectocele or cystocele. So she'll bear down, everything's normal. Pull your hands out, and you're done.
Where were your fingers whenever you were asking her to bear down? Was it on her cervix?
They were not touching her cervix. They were just in the canal.
Okay.
Yeah.
And what do you look for when you look for rectocele or cystocele?
You're looking for tissue to come bulging out at you.
Okay, gotcha.
And then maybe pop back in or maybe not. So that's that. Any other questions? All right, I'll just demonstrate the breast really quick, and then you guys can get going. These breasts are much more realistic to practice with. Just put a little powder on them and keep them clean and lifelike. But there's 3 or 4 different ways you can do a breast exam. I don't really care whichever you prefer, as long as you cover all the breast tissue. That's the most important thing. So I prefer to go horizontally back and forth, just because I'm chatting with my patient at the same time and teaching her breast exams, and it's easier for me to know I've covered all that area without having to actually look and try and do more things at once. You can go up and down, as long as you cover the whole area. You can go in a circle from the nipple outward, as long as you go all the way up to the collarbone and the mid-axillary line. Or you can do spokes from the nipple outward. I like this one the least because some tissue just seems to get missed, but it is an option. I don't care as long as you cover the whole breast. Do whatever feels good to you. So again, it's 3 fingers, the pads of the finger. The hand is flat on the chest. You're not touching the chest, but it's flat against it so that your fingers are flat. And it's light, medium, deep. Light, medium, deep. Light, medium, deep. Medium, deep. You know, when you get down here, it's not like deep, but you need to be able to press through the tissue so that you are knowing that you're getting to the chest wall, that you have felt all the breast tissue from the top to the chest wall, right? And so on bigger breasts, that's going to take a little bit more time, but you just need to make sure you cover your territory. When you go over the nipple, again, it's just normal. You go around the nipple. We're not pressing directly on the nipple, right? We're going all over the areola. And because you're moving in concentric circles, you're going to be feeling the tissue that's underneath the nipple directly without having to be over it. And like I said, we don't typically check for breast discharge, but if someone came in with it, the way you check it is you use both hands, you put them right on either side of the nipple, and you gently squeeze. And then you come from the other side, put the hands on both sides of the nipple, and gently squeeze. If anything is expressed, that's positive for discharge.
But we're not doing that.
We're not doing that, but you need to know how to, just in case you ever do. So that's how you do that. Anything else?
Sounds good.
I think so. All right. So,
I have some questions about
of course.